Okay, so welcome everybody to our 2026 Black Health Equity Speaker Series hosted by DARAO. And to start our session off today, Safeyyah is going to share a land acknowledgement, and she is one of the lovely graduate student assistants that DARAO has the pleasure of working with. So take it away, Salsa.
Good afternoon, everyone, and thank you, Ashley, for a lovely intro. As Ashley mentioned, my name is Safeyyah, and I just would like to begin this speaker series by acknowledging that Western is located on the lands of the Anishinaabe, Haudenosaunee, Lenape-Wauk, Shananton nations, on part of the London Township Treaty Number 6, and connect through Sombra, Longwood, and McKee treaties, and through the Dish with One Spoon Covenant Wampum. I understand the importance of remembering and connecting to our land and our ancestors. In my culture, we place great emphasis on hospitality and respect, which are values I see echoed in the Indigenous teachings. Today, I stand with humility and acknowledge the historical and ongoing injustices that the First Nations, Métis, and Inuit people endure in Canada. So we should all recognize our collective responsibility to reconciliation, not only acknowledging the land, but also actively committing to learn about Indigenous equity. Let us use every opportunity to learn and contribute to a more just and respectful future.
Today's session, we have two speakers. The first speaker is an undergraduate student here at Western University. So Nyechuor Deng is a fourth-year student. She serves also as the Vice President of Outreach for the Canadian Black Nurses Alliance at Western University and is an active member of the Western Fanshawe Student Association. She's also a student representative with the RNAO's Ontario Wound Interest Group. Her passion is for creating positive change, and this actually led to an internship for her with London Health Sciences Centre and involvement with Western Blue, so Western's Black Leadership undergraduate experience, where she promoted the Monk skin tone scale and improved early pressure injury detection for darker skin tones. So today, Nyechuor is here to speak to you about equity in every shade, and I will let her take over and share her presentation now.
You can see my screen well? Good. Okay. All right. So the first question I have for everyone is, have you ever been bruised and how did it look and feel? So today we don't really have a lot of time to discuss. I would love to hear everyone's answers, but this experience of being bruised is something that's unique to everybody. For me personally, I've played basketball for a long time. I've been bruised quite a few times, and I would say that my experience with bruising is something very unique. Sometimes I wouldn't notice unless I bumped my arm on something. I'd be like, "Oh, I definitely did hurt myself there." And given I have a very dark complexion, it doesn't really show well. So therefore, bruising and is something that we can really acknowledge that is very different for everybody. And it's something as small as that. We can see that in healthcare that skin, how skin lesions show and how pressure injuries show on different skin color is very different. So let's talk about that. So before we get started, I really want to just talk about these few key terms. So race is a social hierarchy or social category based on perceived physical traits. And so something like skin color, like for example, someone who's black or someone who is white, that is something that is like race. And ethnicity is a shared culture, language, ancestry, and also history. So for example, my nationality is Canadian, but my ethnic background is South Sudanese. Skin tone would be, or skin color is the visible melanin on your skin, and is a very wide variety of skin tones. And then colorism is a bias based on how light someone is or how dark someone is. And this is often used in really bad ways and really to justify some racism that may happen in healthcare or just in our society. So there are many gaps that show up in healthcare, specifically with skin tone. So in healthcare, when we do open up our textbooks or when we are in school or whatnot, we do see a large representation of lighter skin, which is something that is very alarming, I would say, because when you go to the real world and you really look around, there's a diverse amount of people that we see, and specifically in the hospital as well. So about 4 to 10% of clinical textbooks only represent dark skin, which is something that should be looked at into, and we should improve the amount of darker skin that is represented in our textbooks. Foundational nursing textbooks also have an underrepresent dark skin in core content, including skin and wound assessment, which is really important in healthcare because we do see a large amount of underrepresentation of dark skin in the healthcare system. Something like SpO2 monitors and pulse oximeters have been found to be inaccurate in dark skin, which is something quite alarming because this also led to Black patients during COVID-19 being sent home with bad SpO2 readings, but unfortunately the SpO2 monitor did not really read that. And so when they came back, they were sicker, and obviously there's more complications. And international pressure injury guidelines also acknowledge that stage 1 pressure injuries look very different on darkly pigmented skin and give little practical guideline on how to assess pressure 1 injuries by the bedside, which we will get into. So pressure 1 injuries are basically a spot on your skin that is damaged from too much pressure. So maybe on bony prominences on your body, that's where pressure injuries usually occur. And they may look dark, purple, or discolored. And the skin is usually closed and intact. It may feel painful, sore, or just maybe very different compared to the surrounding skin. So as I said, this really happens when you sit on your skin for a long time. And for patients who are in the hospital for weeks or months are at a large, they usually do get pressure injuries. They're at a higher variability. And so it's really important that we really understand how we can detect these pressure injuries, specifically on darker skin, because they do look very different. So on lighter skin, we really rely on the erythema, redness, and maybe the discoloration of the skin because it is more visible. But on darker skin, it is very subtle. It looks purple, blue, gray, ashen, and not visible. As I said earlier, my bruise, when I see it, I really don't see it unless I touch it and it hurts. Maybe a couple days after, it does look a little, maybe the skin looks a little bit more shiny or maybe a little bit more darkened. So if we go to the healthcare field and we see that pressure injuries are not being detected, which can lead to even bigger complications, even like, they can get infected and then maybe this wound will open. It could really, really cause even more complications that will danger our patients. So if our mental picture of compromised skin is redness, we underdiagnose early damage on darker skin tones. So there's obviously a cost of getting it wrong, and unfortunately, people with darker skin are about twice as likely to develop more severe stage 2 and then stage 3, 4 pressure injuries than those with lighter skin, in part because early damage is hard to see, unfortunately. So a US study also saw 6 million pressure injuries over 10 years and found that African American patients had a higher risk of pressure injuries, sepsis, death compared to white patients. So in the healthcare system, we obviously have tools, but some of the tools may be a little bit outdated. So one of the tools I really want to highlight is the Fitzpatrick scale. So this scale was created to categorize skin based off of UV reaction and UV exposure on how skin burns and tans. It is used in medical research to assess sunburn, as I said, and pigmentation disorders and laser treatments, so suitability. So if we look at this chart from 1, 2, 3, 4, and then 5 and 6, we can see a very big gap between 5 and 6. And this gap really takes away the diversity and the variability that we should have in healthcare. And so this will obviously cause limitations. And unfortunately, this will misrepresent people of darker skin and then obviously becoming less inclusive in medical diagnosis. So one of the tools that was created recently is called the Monk Skin Tone Scale. It was created by Dr. Ellis Monk, someone who went to Harvard, and he initially created it for AI, and AI also has an issue with detecting diverse skin tones. And so he created this skin tone scale to really help AI detect diverse skin tone. And fortunately for us in healthcare, we were able to also use it to detect pressure 1 injuries and just any type of skin injuries in healthcare, and to address the biases in medical imaging, skincare, and AI as well. So, as stated before, I did an internship with LHSC, and fortunately, we were able to use the Monk Skin Tone Scale to help nurses really round their skills on how to detect pressure injuries on darker skin. So we used it during our pressure injury prevalence survey, and we were able to help nurses learn about how pressure injuries and how different skin lesions may appear on darker skin, and how we can really detect stage 1 injuries before they get worse for patients with darker skin tone. And it was a success, and hopefully we are able to continue to use it and develop even better tools by the bedside for nurses. So in another hospital, I was able to work with Rebecca and to really understand how they have been moving forward with skin inclusivity in healthcare. And Rebecca has developed a 4T skin assessment. And so it's a bedside tool that nurses and healthcare workers can use to assess skin tone. And it guides nurses on how to assess tone, temperature, texture, and tenderness, and not just the redness of the skin. So this tool essentially helps nurses detect stage 1 injuries before they get worse on people of darker skin and skin tone. So there are many challenges to change. We do have a limited amount of data on how often pressure injuries are missed in this stage on darker skin tone. We have fewer educational resources, as stated earlier as well, on how wound images are used and how they do not feature a lot of darker skin. And there's also a misconception among staff who may think that realizing that a patient may be darker, may be black, maybe just of a different skin tone may sound racist, but trust me, it's not racist. It's really important that we do acknowledge this patient's skin tone, because it is important that that's the first step. Really just understanding that their skin may appear different is really important. And then also diving into how skin lesions or pressure injuries may appear on their skin tone. So I would say that it is really important to teach wound care, not just in the lighter skin, but also in the darker skin. So auditing your learning and teaching is really important. So looking at wound photos that display darker skin tone would be really great for your learning and also for teaching as well. Observing for every stage and every wound type represented across different skin tones is really good as well. Using mannequins and standardized patients who have a diverse skin tone will allow you to have early exposure to people of darker skin, and you'll be able to round your skills even more. And then integrating specific guidance for darker skin as well. So just having, like, for example, the 4Ts, temperature, texture, tone, and those ideas will help you really in healthcare realize that, or help you with your assessments as well, to be able to detect these skin tone or these skin lesions. And then also evidence-based training focused on darker skin also helps nurses' confidence and accuracy when assessing for patients. So my key takeaways for today is that darker skin is still underrepresented and in wound care and then also in images. Gaps in assessment and skills for darker skin tones lead to delayed diagnosis and worse outcomes. Simple bedside tools like the 4Ts or Monk Skin Tone Scale will obviously help you translate your research into real practice. And we need ongoing education, research, and projects to achieve truly skin tone inclusive wound care. So before I end off today, this is like one of my favorite quotes to go by in wound care. In wound care and skin tone equity, we are the ones who have to lead the change at the bedside in policy and education. Faye, Glenn, Abdullah, a great nurse leader in our society. But yeah, thank you so much for listening to my talk. I will pass it on to Ashley.
Thank you so much. That was wonderful. And now I will introduce our second speaker, Safeyyah Raji. And she is the Ontario lead for the Canadian Black Nurses Alliance and a lecturer here at the Arthur Labatt Family School of Nursing. She's also a registered nurse certified in psychiatric and mental health nursing. Her clinical, educational, and leadership work is grounded in mental health advocacy, anti-Black racism, and health equity. Now, through her role with CBNA, or the Canadian Black Nursing Alliance, Safeyyah advances Black nursing leadership, mentorship, and advocacy by supporting initiatives that amplify the lived experiences of Black nurses to inform systemic change in nursing and healthcare across the province and nationally. She is the lead of CBNA's Black Nurses and Students Allied for Success undergraduate mentorship program here at Western University, which I just popped the link to the news article in the chat, where she fosters supportive and affirming environments for Black nursing students. And as an educator, she's very much committed to preparing students to deliver compassionate, person-centered, and equity-oriented care. And so today, Safeyyah is here to speak to you about mentorship and belonging as pathways for Black health equity in nursing. So please take it away, Safeyyah. Thank you.
Well, thank you so much, Ashley, for the very kind introduction. And thank you so much for everyone here on the call for taking time out of your day to join this session. And thank you also to the DARAO committee for inviting me to be a speaker on our series on Black health equities. Okay. So yeah, as Ashley has shared, I'm really excited to have the opportunity to speak about mentorship and belonging and how I've come to understand how they are both pathways in advancing Black health equity in nursing. But before we begin, actually, I wanted to invite everyone to please take a moment and to consider what belonging actually looks like day to day. Belonging as a term in itself can sound quite abstract, but I feel like we can all recognize it when we feel it. So, if you feel comfortable in the chat, or you're welcome to unmute yourself. I think we're pretty good on time to have this discussion, but please share one thing that helps you feel like you belong, whether in your workplace, your learning environment, maybe your personal or professional communities. And I'll give a moment, and maybe I should open up the chat. Anyone wants to share, or you're welcome to unmute yourself as well.
Having a sense of community.
Having a sense of community. Thank you, Michelle, for unmuting. Anyone else? Okay, Dylan in the chat is sharing environment where it supports challenges and allows everyone to be themselves. Yvonne is sharing feeling welcome. Leslie, a warm smile, and all having a voice that is heard. Yolanda feeling a sense of welcome and safety. Charles, warm hugs. I love that. So Sabila, diversity. Thank you. Yeah, thank you all for sharing. And what I'm seeing as a trend amongst everyone's responses, Janet sharing people talking to be Laura, having people included in the conversation, people talking to me. Okay, I figured that. When colleagues talk to me outside from, oh, I love how active everyone is. Thank you. Nyechuor, all having a voice that is heard. Yeah, and so a trend I'm seeing in everyone's responses are like words, supporting like connection, safety, being seen, supported. And thank you all for sharing those reflections. And it's interesting how quickly we can name what belonging feels like when we've experienced it. For me, I didn't have that language at first. I only knew what it felt when I didn't belong. So I want to start my presentation about with my personal journey in nursing, but I also want to acknowledge something important about where I position myself in this work. I'm a Nigerian Ghanaian Muslim woman. I'm the eldest daughter of immigrants, and I was born and raised in Canada. These identities shape my experience navigating nursing, healthcare, academia, and how I move throughout the world. But I also want to note that there's no single Black experience. My story is my story. Our identities, our backgrounds, our privileges, and our barriers do differ, but our patterns do exist. And when individual stories begin to reflect in broader data, we have to pay attention. So So this works. So I came to Western. I did my bachelor's at Western in 2016 as an undergraduate nursing student. And at the time, I was about one of 10 Black nursing students in a cohort of just over 100. I didn't see much representation in my instructors. I didn't see myself reflected in leadership in healthcare. And when I entered clinical learning environments, I learned quickly that not all spaces are created equally. There were many moments where I encountered racism and microaggressions in clinical settings. And what I remember most is that this message or the comments that I received as a student, whether it was directly or indirectly, was to stay quiet, to brush it off, to accept that this is just how things are, to not make it a bigger issue. Growing up, my dad always told me and my siblings that we're always going to have to work 10 times harder than your counterparts to reach the same goal. And I think for many individuals in the Black community, that message becomes normal. You accept it as the baseline and you internalize it. You learn to push through. You learn to adapt while jeopardizing your own health and well-being. And unfortunately, my story is not unique. A provincial report from the Registered Nurses Association of Ontario, RNAO, found that 91% of Black nurses and nursing students experienced discrimination at individual and at institutional levels, and more than 62% reported moderate to severe impacts on their mental health. And when I read statistics like that, I see that systems that were never built with belonging in mind. Because when you're constantly trying to navigate daily interactions, when you feel invisible, you feel misunderstood or undersupported, it really does something to you. It chips away at your confidence, it chips away at your self-worth, it affects how you feel safe to ask certain questions, to challenge the status quo, or even just to share an idea. It can influence whether you pursue formal leadership roles or if you choose to advance your education or career. And over time, it can shape whether you choose to want to stay in the profession. And for me, this is where my story shifts because today I'm no longer sitting in the lecture hall, I'm now standing in front of it. I'm really fortunate to be a lecturer teaching across all years of the undergraduate nursing program at Western. And the student body is far more diverse than it was in 2016. And it is honestly so empowering to see. And there's something powerful to be said about that visibility. I've had students come up to me during class or after class, or they're sending me emails saying, like, you're the first Black nursing instructor I've ever had, and they mention how much it's impacting them and where they see themselves in that profession or in the profession. And I won't pretend that that doesn't mean something to me. There is validation. I do feel a great sense of pride, but there's also that deep sense of responsibility that comes with knowing that your presence may represent a possibility for someone else. Because visibility alone is not enough, and diversity alone does not create belonging. Representation without support still leaves people navigating systems alone. And from now, where I stand as an educator, I don't just think about who's present. I have also more recently been thinking about whether the system they've entered is designed to support them. Because when I look at my Black nursing students, I know what they may encounter, and I feel, as I said, I wouldn't cry. And I feel really sad because I never want them to experience what myself or many other Black nursing students and nurses experience in education and in healthcare. So I've come to realize this, and I do recognize that this is very cheesy, but with diversity comes responsibility. Responsibility in creating learning environments that are not just inclusive in paper or when we look at the data, but in safe nursing practice. Sorry, hold on, let me just finish crying. um, okay. So also responsibility to build systems that support students when they begin their nursing education, and also advocate for systems that continue to support them once they enter the workforce. So recently, the question I've been asking as an educator is, what does it take to move from representation to retention? What does from diversity to belonging, and also from presence to power? And for me, I've been thinking that part of that answer is mentorship. It wasn't, oh, sorry, my slide is loading. Sorry, it wasn't until I experienced mentorship, both formal and informal, that I began to understand belonging differently. Sometimes the mentorship I experienced was informal, like, like a quick conversation, a check-in, even just someone like confirming that what I was experiencing was real and valid. And I also learned that belonging can be created intentionally, and designed through formal mentorship as well. And I remember many moments in my career when I was getting feedback and I was getting comments that, like, you're doing a lot, you're too ambitious, maybe you should slow down. And, sometimes I got the undertone with that kind of messaging also to like wait your turn. And so when I was first interested in teaching and pursuing my master's degree, I was told by a previous nurse manager that I was too young to teach. And if I listened to that voice, I probably wouldn't be speaking with you today. And fortunately, with the support of my husband, I still applied for my master's. And around the same time, I actually got my first part-time teaching contract at the school, which was really very exciting at that time. And during that time, I'm so fortunate to encounter so many forms of mentorship that truly changed the trajectory of my career. So during my master's at the School of Nursing, I received mentorship from the amazing faculty that we have here at the school that really affirmed my potential. At my workplace, at the time, we actually got a new Black nurse educator that joined our unit. Um, and her impact on me was really immediate. She didn't just encourage me, she made room for me. She brought me into working groups. She endorsed me when opportunities arose. She supported me when I chose to do my psychiatric certification. She just normalized my ambition and she made me feel like leadership felt accessible. And that experience that told me that mentorship isn't just about advice, mentorship can really shift trajectories. And for um, and for Black nurses and nursing students, that research demonstrates that access to mentorship has strong correlations to retention, career advancement, and psychological safety. And also, there's something powerful about being mentored by someone who shared aspects of my own lived experience. And this is what the literature and what's on the slide, it's what it calls racially concordant mentorship, which is mentorship from someone of the same racial background. Sorry. I felt that in my experience that there was less explaining, less translating, less proving, and more validation. But I also want to note that I've also experienced mentorship from non-Black mentors who played a pivotal role in my growth, and many of who are here today. So thank you for coming. And so like when I hesitated to apply for a full-time lecturer position at the school, again, telling myself I needed more experience, more time, and even still telling myself that I was too young and in prepping for this, I realized I was still internalizing that feedback that I received from my previous nurse manager a couple of years ago. But it was a non-Black mentor who encouraged me to apply anyway, who saw the capacity in me that I was still questioning. So it just shows for me in my own experience that both forms of mentorship mattered. Racially concordant mentorship offered affirmation. It gave me psychological safety in a way that felt really grounding. But mentorship across different racial identities can also be transformative. But in my experience, and I think it's really important to note, that it does require a lot of intention, accountability, and openness, and also requires willingness to reflect, to listen, and to also support without being defensive as well. And like I said, when that happens, I feel like mentorship can shift trajectories. More recently, my experiences with mentorship have shaped the way I think about Black health equity. Because when we talk about Black health equity, we often focus on client outcomes. And of course, that's really important. But Black health equity in nursing is also about the workforce itself. It's about who feels safe enough to stay in the profession, who advances into those formal leadership roles. It's about who becomes the faculty, the educators, who shapes the policy, who designs curriculum, and who influences care models. If Black nurses are consistently being pushed out or stalled because environments do not support belonging, then I feel like it's not an individual problem, it's a systems problem. And mentorship is one structural intervention that I think interrupts that pattern. So this is where my work expanded beyond my own story. So hopefully I stop crying now. Because mentorship for me moves beyond individual relationships and started becoming about structures, systems, and processes. So that is where I started getting involved through the Canadian Black Nurses Alliance, CBNA, and I just have a photo of the founding members on the screen. And that's where I began to see what mentorship looked like when it was built with intention and purpose. CBNA was founded in 2020, and it's a nonprofit organization committed to dismantling anti-Black racism and nursing education and healthcare across Canada. One of its core pillars, there are many, but one of its core pillars is mentorship. They have both a professional mentorship program for practicing nurses in Canada and an academic mentorship program for students. CBNA's academic mentorship model is called the Black Nurses and Students Allied for Success, also known as BNSAS, and it's actually been running at McMaster University for the past 4 years. And we are incredibly fortunate here at the school through the support of the School of Nursing, the DARAO committee, and the leadership of the director of the school, Dr. Victoria Smythe, to become the first institution outside of McMaster to implement the CBNA program in Canada. Because I feel like this work, it's so important that it can't just live in one school, it also can't live in one person. Through initiatives like I believe Nyechuor shared that she's part of the Western Black Leadership University Experience, the Western Blue program, things like the DARO Committee, the CBNA Western Student Chapter, the Faculty of Health Sciences ADIDA Committee, Office of Equity, Diversity, and Inclusion. Also, what our practice partners are also doing in the realms of ADIDA as well in their own organizations. These are all structures and people who are contributing to this momentum. In my work, bringing this mentorship program to the school, I've had the support of extraordinary student leaders who've helped develop this program. I've been fortunate to work with some amazing, or not in past tense, I am working with amazing mentors, again, some of who are here today. Thank you. And when myself, Ashley, and Danielle were meeting with these mentors at the start of the program, a common phrase that was shared was a lot of them were saying that I didn't have this when I was a student, and this is why I want to volunteer my own time to join this program. And that statement in itself says something. The BNSAS mentorship program isn't just about pairing Black nursing students with Black nurses. It's about creating psychologically safe spaces. It's about professional identity formation. It's about leadership exposure. And I feel, most importantly for me, I feel it's about disrupting isolation early and building belonging intentionally. And research consistently supports that mentorship improves retention, confidence, academic performance, and leadership progression, particularly for students navigating exclusionary systems. But I also want to name something honestly. Much of this work historically has relied on the emotional labor and commitment of Black nurses outside of their work and their professional responsibilities. And they often do this in their own time and with their own resources. And that isn't sustainable in the long run, which is why institutional commitment matters. Committees like DARO matter, funding matters, leadership matters, embedding mentorship into our strategic plans matter. Because if mentorship remains informal and invisible, it also remains fragile. If it becomes structural and built into our system, it becomes lasting beyond any one individual, any one leader. And personally, doing this work has reshaped my academic trajectory. It's deepened my commitment to asking harder questions about how mentorship can be embedded as structural change within nursing education, because the goal is not to just create exceptional students who succeed despite the system. The goal is to create a system where excellence is supported, not just fought for. So when I think about what all this means for those of us joining us today, I think about responsibility. So responsibility to notice who's navigating this alone, responsibility to interrupt silence when harm occurs, responsibility to use whatever positional power and privilege that we hold, whether it is as a student, an educator, a clinician, or a leader, to widen access for everyone. And another thing too is that this work isn't just about perfection, it's about active and intentional participation. And for many Black nurses and nursing students, another thing I wanted to comment on was resilience. Resilience has been a necessary tool for survival in environments shaped by exclusion, bias, and systemic inequities. Resilience reflects strength, it reflects brilliance in our community, and it's something that the Black community should be deeply proud of. But Recently, I've been thinking that resilience should not be a prerequisite for belonging. We should not have to justify to have our presence in academic or professional spaces. We shouldn't have to endure harm in order to demonstrate excellence. And belonging should not depend on our endurance. Belonging needs to be built into the structures. And that is why the work I hope to continue contributing to alongside my amazing colleagues, students, leaders, and my mentors so that future generations of Black nurses do not enter this profession expecting to work 10 times harder, but enter knowing that the structure itself supports their success. So, if I can be, even in a small way, a visible reminder that mentorship and belonging are key in advancing Black health equity, it's a responsibility that I happily carry with a lot of pride. So, thank you. Just some, if you're interested in the work DARAO's doing or CBNA and our CBNA Western chapter, I've just linked that all on the screen, and you're always welcome to email me. Thank you.
So, thank you everybody for your lunch hour and for your time and coming to this space to listen and have a conversation. I am so grateful for both of our speakers and taking the time out of their day to share their lived experiences and to share some of the really critical work that they're doing in both educational and clinical practice context to really disrupt anti-Black racism. So, cheers to our speakers, and I hope everybody has a wonderful rest of your day. All right. Thank you, everybody, for today.